Hey everyone, we're going to wrap up our chapter on veins, arteries, and circulation with this video, which you might be looking at the PowerPoint right now thinking, how the heck is she going to cover all that in one video? I'm not actually, because a lot of it is covered in lab. So anyways, we ended off talking about the pulmonary circuit in our last video, and now we're going to talk about the systemic circuit and the systemic vessels. So let's start with that. So on our arterial side, our systemic vessels, everything branches off the aorta. The aorta is the largest elastic artery in the body. It goes from the left ventricle, and it has an ascending part, an arch, and then a descending section, which basically travels all the way through your thoracic cavity and abdomen, and then it branches from there, and we'll see that in the subsequent slides. Then our venous system is basically all leading to our superior and inferior vena cava. The superior vena cava drains all of the veins from our head, neck, upper limbs, right? Chest area. Our inferior vena cava is draining all of the blood basically underneath of the diaphragm. So anything, trunk, lower limbs, abdomen, all coming in through the inferior vena cava to the bottom side of our right atrium. Here you can see all of the arteries of the body. Again, you can see that aorta starts with ascending, the aortic arch, and then descending, and then it branches at about belly button level into our common iliac arteries, which then branch from there. And so let's remember, for example, what I was mentioning in the last lecture about how our vessel names change. If we follow, for instance, our descending aorta branches at, again, about belly button height into our common iliac. So you have a right and left common iliac. Everything is symmetrical in terms of vessels, few exceptions to that. So you have your right or left common iliac artery. Pick one to follow. So we'll follow the left. So the left common iliac artery is going to branch into an internal and external iliac artery. And if we follow this external iliac artery down through our pelvic bones, we'll get to the femoral artery. So this femoral artery then follows down, and eventually it branches into our anterior and posterior tibial arteries. So you see how it's the same road, so to speak. It just changes names based upon where it is in the body. That's what our blood vessels do. On your lab practicals, you'll obviously have to identify these. On your lab quizzes and lecture exams, I'm not going to give you diagrams, but I may ask you specific questions about different vessels in the body. So for instance, I might say so-and-so had an injury to this part of the body, name the blood vessels in that area, right? And then you have to come up with the vessels that are within that area. Same thing with the veins. They do the same thing. They're just bringing the blood back up to the heart. So our overall systemic vessels are very similar on both sides. One major significant difference is the distribution that's within the neck and the upper limbs. So arteries tend to be deep to the skin, protected by bones and soft tissues. And we'll talk about some of these differences as we go. One significant difference between artery and vein distribution is veins are generally in two sets. Veins generally have a superficial and a deep version. So this is very important in controlling body temperature. Remember, we said one of the functions of blood is to maintain stable pH and maintain stable temperature. So the venous blood that flows superficially in hot weather to allow heat to escape from the body, and the venous blood flows deep in cold weather or cold temperatures to conserve heat and keep it closer to the core of the body, so you don't lose too much. So here's a little area we can stop and reflect on what I just went through, and we're going to keep marching through. Like I said, we're going to finish the whole chapter in this video. So I'm not going to go through all of these vessels. Do you have to know all of them? I'm going to say you need to know like 95% of these veins and arteries. There's very few that you do not need to know. So when I say know them, you need to be able to identify them on a diagram or on a model in lab. And when I talk about them on a test or quiz, you should be familiar with where I'm speaking about. It's not tricky though. We know the muscles, we know the bones, and we know the regions of the body. So when I say something like brachiocephalic, you should be able to recognize that prefix brachio, like arm, cephalic, like head. It's somewhere in this area. Well, the brachiocephalic is actually going to divide into the common carotid, which goes up to your brain, and the subclavian, which goes underneath your clavicle over to your shoulder. So once you know the regions of the body, the bones and the muscles, you pretty much know the vessels. So, and these, of course, are the arteries, which 99% of them have a vein that's named the exact same thing. So you have a vertebral artery and you have a vertebral vein. Axillary artery, brachial artery, same thing. You have veins that are named the same thing. These are branches from the subclavian. I'm going to flip through all of these, and so you have this big PowerPoint. If you printed it all out, you have this huge PowerPoint of all of these veins and arteries that I'm skipping through because we're going to cover these in lab over a period of about 2 weeks in lab. And so I skip through all of this. These are the veins, and keep on jumping through. This talks about the branches off of the aorta. And eventually we get to our next little section, which is here, our disorders that are related to our circulation. So there's fetal circulation, which obviously isn't a disorder, right? This is just something different that's a variant of what we know or what we all have just learned in this chapter. So in fetal circulation, you have umbilical arteries and an umbilical vein. The umbilical arteries carry blood from the fetus to the placenta. So again, they're carrying blood away. They're carrying blood away from the fetus. They run from the internal iliac arteries of the fetus to the umbilical cord and then out to the placenta. The umbilical vein carries blood from the placenta. It's bringing oxygen and nutrients, and it drains into something called the ductus venosus. All the umbilical vessels degenerate after birth, and there are remnants of them in our adult selves, and we'll talk about some of those. The ductus venosus is a little connection between the veins, to the veins within the liver. And so this is connecting the blood from the liver from the umbilical vein. And of course, it empties into the inferior vena cava of the fetus, and then it circulates, just with the beating of the heart. In another fetal feature is called the foramen ovale, or the intra-arterial opening. It's actually a hole in your heart. Fetuses, unborn babies, have a hole between their atria. This is going to allow the blood to flow from this ductus venosus, which jumped into the right atrium, right, inferior vena cava, to the right atrium. And now this right atrium blood is going to go into the left atrium. Why does it need to do that? Because the unborn baby doesn't breathe, right? It's in it's in the amniotic fluid. It can't breathe, right? The lungs are not functioning at this point. The lungs don't function until after birth. So there's no reason to run that pulmonary circuit. The whole pulmonary circuit is in fact turned off in the fetus. So you have this large amount of blood coming to the right atrium, going through the foramen ovale to the left atrium, where it can go to the left ventricle and then pump throughout the fetal circulation. So that foramen ovale is a bypass of the pulmonary circuit. It has a one-way valve, so the blood can't flow backwards, goes one direction. There's also the ductus arteriosus. The ductus arteriosus is just in case there's some blood that doesn't quite make it through the foramen ovale and goes into the right ventricle and is actually pumped out to the lungs. The ductus arteriosus is a little passageway from the pulmonary trunk to the aortic arch. So any blood that's going to the lungs is actually going to go back up to the aorta instead of going to the lungs. So it's sent from the right ventricle to the systemic circuit. And here you see that passageway. Notice the blood is not going over to the lungs. There's no pulmonary circuit in the fetus. It's coming in through our umbilical vein right here and leaving, going in through the ductus venosus and going into the inferior vena cava, right atrium, from the right atrium going to the left atrium through our foramen ovale or through the ductus arteriosus into our aortic arch. Right? And then the blood continues to flow and eventually leads back into our umbilical arteries, which leave the same passageway through the umbilical cord and go out to the placenta and eventually, get to the mother. So there's changes in circulation that occur at birth. Obviously, we don't have holes in our heart, hopefully, and we don't have that ductus arteriosus. Our blood is not flowing in through our belly buttons anymore. So these changes obviously occur because our pulmonary vessels dilate, and that's response to pressure changes. This baby is kind of like in a vacuum almost, right? So those lungs are not exposed to differential pressure, like we are. We have this atmospheric pressure, and then there's pressure inside of our lungs, which brings the air in as we breathe. It's a passive process. And then likewise, when we exhale, it's not like that in the fetus. It's maintained in this kind of vacuum-like setting. So when the baby's born, and now it suddenly hits that air, it has this change in pressure. So air rushes into the lungs, and it expands the pulmonary cavities and allows for those vessels to now dilate and become usable. So this increasing pressure that's in the left atrium is going to close that foramen ovale, and it's going to lock. It should lock, right? It's closed and shut in place. And what you have left is something called a fossa ovalis. It's just a deep or a shallow depression rather. You can see it inside the wall of the right atrium. The rising oxygen levels is going to cause the ductus arteriosus to close as well. And the remnant of that is called the ligamentum arteriosum. It's a little ligament that attaches our pulmonary trunk to our aortic arch. It's not a vessel anymore. It's just a little ligament that's left over. There you can see the ductus arteriosus and our foramen ovale, which is now closed. So there are ventricular septal defects that can occur, or openings maybe in the interventricular septum, most common congenital heart problem, and it's still less than 1% of newborns. This is going to cause a mixing of oxygenated and deoxygenated blood, and generally you wouldn't even know that until later in life, and then a small surgery can just fix that. So there's a patent foramen ovale, which is when that foramen ovale remains open. This is going to cause this left to right shunt and causing the blood to recirculate through the pulmonary circuit, normal oxygen content, but the left ventricle has to work harder to get that blood up and out and have increased pressure. There's also patent ductus arteriosus, where that passageway remains open, and this creates the right to left shunt, so blood is not adequately oxygenated, so the skin could be bluish, and the person could suffer from obvious issues related to low oxygen content. There's also tetralogy of Fallot, which is a very complex group of defects. It's not just one thing, it's a whole bunch of them. Again, less than 1% of newborns have this, and it's actually 4 main defects that are involved. One is a very narrow pulmonary trunk. The interventricular septum is incomplete, so that allows for that oxygenated, deoxygenated mixing. The aorta is actually originating where the interventricular septum would end, so at the bottom, and then the right ventricle is then enlarged because it has an increased workload. And you can see this here. Our aorta is beginning much lower than it would be. It would normally be further up. And so you have this mixing that occurs, and a series of surgeries, very serious surgeries, would occur pretty much right after birth. There's also atrioventricular septal defect. This is when the atrium ventricles are incompletely separated. And this is a variable affect disorder, so it depends on how poorly that interventricular septum is formed. It can affect the AV valves, the valves in between the atrium ventricles. Most commonly occurs actually in individuals who have Down syndrome. So it's actually caused by the presence of chromosome 21. And there you see the heart. An atrioventricular defect, those walls are not completely formed. There's also the transposition of great vessels. This is when the aorta is connected to the right ventricle and the pulmonary artery is connected to the left ventricle. So you have this kind of switching that occurs of the pulmonary systemic circuits. Very dangerous. Surgery has to fix that as well. So this concludes our lecture on chapter 18. And as I said, all the vessels that we skim through, we're going to learn about them in detail, where they are, what they do in lab. As always, let me know what questions you have. I'd be happy to help you, and have an awesome day.